Good morning, good afternoon, and good evening from wherever you guys are going to watch this. My name is Shyamali Joseph. I'm from Avalon University School of Medicine, and I'm with AMIQT now. I'm going to be discussing Miller-Fisher syndrome, or otherwise known as a Miller-Fisher variant of Guillain-Barré. We're going to go into the background. I'm going to discuss a case study of a case that I personally saw in the ER. Then we're going to discuss the epidemiology, the clinical presentation, etiology, pathogenesis, pathophysiology, the differentials for Miller-Fisher syndrome, the treatment and management, and the prognosis and complications. And we're going to do a small discussion in the end as well. So I'm just going to go into a little bit of the background. Miller-Fisher syndrome is a rare variant of acute inflammatory demyelinating polyneuropathy, or AIDP, also known as Guillain-Barré. It was first recognized in 1932 by James Collier, who described it as a triad of ophthalmoplegia, ataxia, and areflexia. Then later on, Dr. Miller-Fisher classified it as a variant of Guillain-Barré, and that happened in 1956. Miller-Fisher syndrome is an important differential diagnosis when we consider in patients with acute or subacute flaccid descending paralysis, and is quite often overlooked in favor of other differential diagnoses with similar presentations such as stroke, myasthenia gravis, electrolyte abnormalities, and wound botulism. So I'll first present a case that I encountered at an emergency department. So the patient is a 21-year-old female who was brought in by her father after losing her ability to talk when she woke up that morning. And since the patient was unable to vocalize, the historian in the case was mainly the patient's father. He reported that the patient had a dull global headache the previous night, which resolved with administration of paracetamol orally. But other than that, her condition was normal until that morning. However, the father also noted that she had received treatment for loose stools about 4 weeks prior to the visit at the ER. Aside from the recent diarrheal episode, the patient's medical history was unremarkable. Her family history was also unremarkable. Physical exam revealed bilateral ophthalmoplegia with right-sided lower motor neuron type 7 nerve palsy. We also noted that the patient had a very apparent ataxic gait. Her pulse was elevated at 110 beats per minute, and her oxygen saturation was borderline because it was about 96% on room air. On physical exam, the muscle tone was decreased with 3 out of 5 power in all 4 limbs, and the sensation to pain, temperature, and touch vibration position was maintained in all of 4 limbs. Neuroimaging revealed no abnormal findings, and nerve conduction studies showed pure motor polyneuropathy. At this point, Miller-Fisher syndrome was highly suspected due to her presenting symptoms and ruling out of other differential diagnoses. We proceeded with IVIG treatment with the hope of accelerating her recovery. Within 2 hours of her admission to the emergency room, the patient's condition rapidly deteriorated. Oxygen saturation dropped to 86% on room air, and we had to provide ventilatory support to avoid respiratory arrest. Following intubation, the patient was transferred to the ICU for continuous ventilatory support, as well as cardiac monitoring. Following intubation and oxygen support, the patient's condition continued to rapidly deteriorate. We transferred her to the ICU for continuous ventilatory support, as I said, but paralysis quickly descended, ending with full body paralysis in just a few hours. At this point, we referred the patient to a higher care center. Now we're going to talk about the epidemiology of Miller-Fisher syndrome. As I mentioned in the background, the worldwide incidence of Guillain-Barré is about 1 to 2 per 100,000 cases, per 100,000 people, with the Miller-Fisher variant of GBS making up only a tiny subset of the cases, about 1 to 2 in a million. While studies estimate that the Miller-Fisher variant makes up just about 1 to 7% of Guillain-Barré cases in the West, it makes up about 15 to 25% of cases in Asia. Men make up the majority of cases. It's also been observed that the majority of cases occur during the winter and spring. This is specifically for the Miller-Fisher variant of Guillain-Barré. It affects all ages, although adults are more frequently affected than children, and the average age of onset is 43.6 years. In terms of how it presents, the cardinal clinical features are the triad of ophthalmoplegia, ataxia, and areflexia. Ophthalmoplegia and ataxia almost always precede the areflexia and Miller-Fisher, which is also the least common of the three to present. And specifically, the presentation of ophthalmoplegia most commonly being external, bilateral, and symmetric. It generally progresses from an up gaze to a lateral gaze and then to a down gaze. So that's very significant of the ophthalmoplegia seen in Miller-Fisher syndrome. The ataxia in Miller-Fisher syndrome can be so severe that the patient loses the ability to walk independently. And the clinical severity of the symptoms is directly correlated with the level of anti-GQ1B antibody present in the patient. Other neurological signs and symptoms may also be present, such as limb dysesthesia, blepharoptosis, face, bulbar, and pupillary palsies, and there may be a mild grade 4 motor weakness and some mild micturition disturbance. Unlike the classic ascending weakness or paralysis characteristic of the more common variants of Guillain-Barré syndrome, neurological deficits follow a top-down pattern in Miller-Fisher, starting with diplopia in the eyes, caused by the external ophthalmoplegia, of course, and then which is the most common symptom. In terms of etiology and the pathogenesis of Miller-Fisher syndrome, Miller-Fisher syndrome and Guillain-Barré are thought to result from an abnormal acute autoimmune response to a preceding infection. In terms of Miller-Fisher, Campylobacter jejuni and Haemophilus influenza have been the most commonly implicated pathogens. However, there are multiple other pathogens such as Mycoplasma pneumonia and cytomegalovirus, which are also associated with Miller-Fisher syndrome. Upper respiratory infection is the most commonly described prodromic entity, which is then closely followed by gastrointestinal illness, as seen in our case study. The predominant theory regarding the pathogenesis is that there's a cross-reaction between peripheral nerve antigens and microbial or viral components. And this is thought to occur through molecular mimicry. And this drives the autoimmune process seen in Miller-Fisher syndrome. And this augmented autoimmune response can be directed towards the myelin sheaths or the axon of peripheral nerves. Studies by Buchwald et al. Have demonstrated that a neuromuscular block using the anti-GQ1B immunoglobulin G, this suggests that the mediator of this, that the anti-GQ1B Ig is a mediator of symptoms in Miller-Fisher syndrome. Because anti-GQ1B monoclonal antibody has also been shown in mice studies to block a neuromuscular transmission with an effect closely resembling the paralytic toxin, neurotoxin latrotoxin in the neuromuscular junction. There is further evidence of this theory that the third, fourth, sixth cranial nerves contain appreciable amounts of GQ1B ganglioside, and they can be stained using fluorescent labeled anti-GQ1B monoclonal antibodies. The frequency of involvement of ophthalmoparesis in myasthenia gravis, which itself results from a neuromuscular blockade, also supports the proposed pathogenic mechanism. Um, Despite the plausibility of this theory, patients with Miller-Fisher syndrome lack any clinical evidence of fatigability, which is unlike patients with myasthenia gravis, nor is there any neurophysiological evidence to substantiate a defect in the neuromuscular junction of patients with Miller-Fisher syndrome. Most patients with Miller-Fisher variant of GBS report symptoms of either an upper respiratory tract or gastrointestinal infection, with upper respiratory tract infection being more common prior to the onset of any neurological symptoms. The infection can occur anytime from 3 days to about 6 weeks before the onset of neurological symptoms. And as in our case, the patient had a diarrheal episode 4 weeks prior, which she was treated with antibiotics. And then the median time of onset of the pro-infection is 8 days. Generally, the causative organism is not identified. However, when it is identified, Campylobacter jejuni is the leading cause, followed by Haemophilus influenza. More recently, cytomegalovirus and Mycoplasma pneumoniae, Epstein-Barr, and Group A Streptococcus, Coxiella burnetii, and Pasteurella multicoida, H. pylori, Aspergillus, and Varicella zoster have also been identified preceding the onset of Miller-Fisher syndrome. Miller-Fisher syndrome can be misdiagnosed very often because it has a similar clinical presentation to other disorders. The most common differentials we see is like the Bickerstaff brainstem encephalitis, which is also another variant of Guillain-Barré, and pharyngeal cervical brachial weakness, which is also another variant of Guillain-Barré. All three of the disorders, which is Miller-Fisher variant, the Bickerstaff brainstem encephalitis, and pharyngeal cervical brachial weakness, have the presence of anti-ganglioside antibodies in the CSF. The key distinctive features of brainstem encephalitis are the presence of hyperreflexia and encephalopathy, which are not seen in Miller-Fisher syndrome. The pharyngeal cervical brachial variant of Guillain-Barré presents with acute weakness of the oropharyngeal oropharynx, neck, and shoulder muscles, as well as dysphagia and facial paresis. However, in these patients, reflexes and strength in the lower extremities is preserved, which it's not preserved in patients with Miller-Fisher syndrome. And also, what differentiates Miller-Fisher syndrome is that its onset is gradual, and that gradual onset is a key factor in distinguishing it from acute brainstem stroke. Other differential diagnoses we should consider are Wernicke's encephalopathy, ocular myasthenia gravis, Lambert-Eaton syndrome, multiple sclerosis, sarcoidosis. Neuroimaging and electrodiagnostic testing, which is basically EMG and nerve conduction tests or evoked potential tests, can help generally exclude these alternative diagnoses. In terms of diagnosis and evaluation, the diagnosis of Miller-Fisher syndrome is mainly clinical. However, additional testing is helpful in ruling out other diseases, including the other variants of Guillain-Barré that were previously mentioned. Extraocular muscle assessment should be performed to document the type, the severity of any ophthalmoplegia that may be present. And a pupil examination should be also conducted to check for internal ophthalmoplegia. And then neurological evaluation for peripheral neuropathy, gait ataxia, and deep tendon reflex should also be performed. In Miller-Fisher syndrome, neuroimaging is often normal, and that's what will also help rule out Miller-Fisher as opposed to other the other differentials we talked about. However, in a small percentage of people, 1% of patients, non-specific MRI abnormalities may be present. Abnormalities like faint enhancement or T2 signal in the brainstem, cerebellum, posterior columns, and nerve roots have been observed in rare cases of Miller-Fisher syndrome. Also, CSF studies can indicate the presence of albuminocytological dissociation. And what albuminocytological dissociation is basically you'll see high protein CSF with low CSF white blood cell counts. But it's not specific to Miller-Fisher syndrome because albuminocytological dissociation is commonly seen in other neuroimmunological disorders, such as the other variants of GBS like Bickerstaff brainstem encephalopathy. Serological studies are also key in diagnosing Miller-Fisher syndrome. Serological studies generally show anti-GQ1B antibodies. They're usually present within 1 week of onset of symptoms. EMG and nerve conduction studies are typically normal in Miller-Fisher syndrome, but they are helpful in diagnosing other subtypes of GBS. In Miller-Fisher patients, the most common EMG finding is the absence of soleus H reflex, which is a sign generally of a proximal conduction impairment affecting only group 1A neurons. The ataxia and areflexia commonly seen in Miller-Fisher syndrome can likely be explained by conduction abnormalities in 1A spinocerebellar afferent fibers or muscle spindles. And a much less common sign in Miller-Fisher syndrome cases is abnormal F-wave latency. And this indicates conduction impairment in the spinal roots, limb girdle plexuses, and proximal segments of nerves. And this is likely due to demyelination. In terms of treatment and management, Miller-Fisher syndrome is usually a self-limiting condition and has a very good prognosis, especially the limited forms like acute ophthalmoplegia without ataxia. That's a subtype of Miller-Fisher syndrome. And most patients recover completely, regardless of treatment modality. Randomized control trials have not yet been conducted to evaluate treatments for Miller-Fisher syndrome. However, retrospective studies do indicate that IVIG improves recovery times without negatively impacting long-term outcome. And despite a lack of any evidence that corticosteroids have any impact on recovery times or outcome, different combinations of IVIG, plasmapheresis, and corticosteroids are generally used to treat patients with Miller-Fisher syndrome. And in severe cases of Miller-Fisher syndrome, patients, this is with patients who have extreme swallowing and respiratory difficulties, they should be treated with IVIG. IVIG is also preferred treatment of modality versus plasmapheresis due to the convenience, availability, and minimal incidence of adverse effects. However, the cost of IVIG should be considered and may be prohibitive for low income and underinsured patients. So, that's something to keep in mind. The outcome of patients with Miller-Fisher syndrome is generally good. It has a very low fatality rate of, I think, less than 5%. Recovery times range between 8 to 12 weeks. Some patients may experience residual symptoms. Recurrence is, though quite rare, has been reported in literature. And the top predictors of morbidity and mortality are the respiratory status and complications of the patient who has Miller-Fisher and is in the ICU. So about 21 to 48% of Guillain-Barré patients can suffer hyponatremia, and 3/4 of patients with Guillain-Barré syndrome and Miller-Fisher syndrome report generalized fatigue. Patients with Miller-Fisher variant of Guillain-Barré tend to have a better recovery than patients with other variants of Guillain-Barré. 1/3 of patients with Miller-Fisher syndrome report experiencing pain even 1 year after initial onset. And patients with extended stays in ICU tend to have a more severe complications. which include sepsis, pneumonia, pulmonary embolism, deep vein thrombosis, from immobilization, and gastrointestinal bleeding. Other complications faced by patients who have had Miller-Fisher syndrome include arrhythmias, ileus, and in patients who have Miller-Fisher over the age of 50, respiratory muscle fatigue is a worrying complication due to the risk of mortality from respiratory failure. 20 to 33% of patients with severe cases may be unable to walk for more than 6 months after initial onset of symptoms, especially if they had a prior C. jejuni infection. There's also a psychiatric component to persistent pain and disability, which is encountered by patients. Before wrapping up, I wanted to touch on some recent findings that have come up regarding COVID-19 and Miller-Fisher syndrome. So there have been 25 reported cases of Miller-Fisher syndrome preceding a recent COVID infection with a preceding COVID infection or COVID vaccination. Both have been identified as a new potential cause of Miller-Fisher syndrome. However, these cases are unique because these patients are generally negative for the anti-GQ1B antibodies. And so this calls into question the exact pathophysiology of COVID-19 infection, leading to demyelination of the peripheral nervous system, and more research is needed to answer that. So thank you very much. I hope this has been helpful, and these are my reference lists.